Thank you, Linnell. And now a few practical notes. If everyone could please silence your cell phones, but don't put them away. We're on Twitter at AtlanticLIVE, and we would love for everyone to join the conversation using the hashtag AtlanticExploresCancer. And we're going to leave time after the interviews for your questions as well, so we'll have someone walking throughout the audience with a microphone, so please be on the lookout. And now we're going to explore the spirit of collaboration here in the Pacific Northwest medical community. So please welcome Terry McDonnell, Vice President of Clinical Operations and Chief Nurse Executive of Seattle Cancer Care Alliance, and Veena Shankaran, Interim Co-Director of the Hutchinson Institute for Cancer Outcomes Research. And here to lead the conversation is the Atlantic's Washington Editor-at-Large and my colleague, Steve Clemons. So Steve, the floor is yours.
Thank you. Thank you so much, Emily. Good to be with everybody. I just want to say it has been so much fun. Good to see you both. And we're going to have a fun discussion. Hopefully you guys will have questions and comments and we can bring this all together. I just want to point out everyone in the audience tonight is extraordinary, but there's some good friends that came from far away. Just former Congressman Brian Baird is a very good friend of mine from Washington. He doesn't really want to be pointed out, but the D.C. people. John Graham, who's the new regional director here for HHS, it could be a good resource for many of you. I know these kinds of rooms make me uncomfortable sometimes because all of you are so good. I'm a person who thrives in darkness and cynicism, and usually, half the people in a room that I'm in are really bad people. But here we've got a lot of good folks. We've done these forums all around the United States. We've been in Las Vegas, we've been in Minneapolis, Tampa, and every community that I have visited and had the privilege to spend time with has different features of how they deal with the broad cancer challenge, which is something that runs through the country and frankly the world, but through the country does. And so I thought, Terry, I'd start with you, well, both of you, and just ask you, can you tell us a little bit about the Seattle Cancer Care Alliance and what makes it special and unique here?
Thank you. Well, the Seattle Cancer Care Alliance came about because 3 institutions about 20 years ago, the Fred Hutch, the University of Washington, and Seattle Children's, decided that they wanted to do something that was innovative and groundbreaking around cancer care. So they came together and they created the Seattle Cancer Care Alliance, which is a dedicated cancer center. And all these years later, we are the coming together of research, innovation, academics, and patient care. And I've practiced in other areas of the country, and I will say that this is truly groundbreaking, even to this day, 20 years later.
Veena, what can you add to are you part of this network?
Well, I am part of the network. Real quick, if you don't mind, just
Sure.
one
Yeah.
quick housekeeping thing.
Yeah.
I was told that I have to disclose that I am a principal investigator of 2 BMS trials at University of Washington.
There's now going to be a major front page article about that tomorrow. So glad you put that out there.
But yes,
But are you part of this network?
I am. I wear many different hats. I am a clinician at Seattle Cancer Care Alliance. I take care of patients with gastrointestinal cancers. And I'm also a researcher, and my primary research role is part of the Hutchinson Institute for Cancer Outcomes Research. And our job is, through research, to reduce the human and economic burden of cancer. And so we've come together with multiple institutions in the Seattle, Puget Sound, Washington State region, actually, to use data to represent our treatment and outcomes across the state.
So you mentioned data, and feel free to jump on anything. When I go to Cambridge, Massachusetts, and I find that institutions there pretend to share data, but you also have data hoarders. And that we want to put kind of a rah-rah smile on a lot of this stuff, but the world of data sharing and data management is a lot rockier than I think the public may know about it. What is it like here? Do you find anyone defecting from the sharing side of this? Are there any selfish data hoarders in Seattle?
Well, I think that I'm sure there are. I like to think that.
Which one? You thought this was going to be easy.
You know, I think that one of the challenges is trying to get better systems to share data amongst different entities across the research world, between clinic and research communities. And so I think that's part of what we're trying to do within HiCore, which is to bring clinicians, patients, and researchers together to utilize the data that we have to take better care of patients and
Terry,
understand
you want
care.
to point a finger at someone?
No. But what I will say is I do see that there is a shift in the approach, and that is patient-reported data. And we're really seeking to get data from the patients, and that's one of the really neat things coming out of the Alliance and HiCore right now is patient-reported outcomes and how we use technology to communicate with the patients to get the data directly from them. Because there's the big data sharing, but then there's the data you need for the care.
And so do you find trust building there with the patients that used to not be there?
Yeah. You know, anytime you can reach out and get a patient to interface with you and give you information, whether it's by phone, in person, on an app, the world is changing. It used to be you met face-to-face with your patient, and that was the time at which you got the information. Now it's text messaging and phone calls and emails, and the world has evolved.
Do you know, there's so many different dimensions I would like to go into, but one of them I want to ask you about, because it's been something that's come up in a lot of other communities, is that there are some communities that are in, some would call them privileged communities. So they have a high level of literacy about engagement on these issues. They know where the resources are. What about underserved communities? Do you reach them? Are they participating in clinical trials? Do you feel like you're making progress in reaching parts of the communities that I have to tell you, if you go to Minneapolis, it's a huge issue there about how, in fact, the entire forum was really much about strategies to reach Native American communities, reach the African American community, reach Hispanic communities that were not as participatory and built in, if you will, as others. So what's the situation here, Terry?
Well, we're trying to go at it at a number of different levels. So, you know, you go into the community, you do your outreach. We've got a mammography van, and we try to go into areas that are specifically not served by other centers, where there's limited access. The King County Health Fair, we are huge participants in because we want to help the members that live within our community. We do a lot of charity care. There's a lot that we do to make sure that we reach into and are able to capture as much of the community as possible, whether privileged or underserved.
You know, on the research side, do you have those challenges?
We do, and we've heard a lot from, well, I'll echo Terry's earlier comment that patients are extremely engaged in the process of research, trying to inform the research questions and inform the research studies we're doing. We've incorporated the patient advocates and patient voice in our annual summits, research summits, to try and understand what these issues are. We've heard loud and clear that it's critical in research to collect patient-reported outcomes, and we're in the process of trying to identify what those important measures should be. But the truth is there are disparities, and there are some people that are more difficult to reach, and so from a state data level, we're trying to use our data to understand where there are disparities and figure out what communities need to be lifted up, where the variability in care is, and try and focus our research efforts in those areas.
So it sounds like when you have a phenomenal network, and the Alliance sounds like it brings in a lot of players and factors. If you were to look at your strategic plan and say, 10 years from now, we need to fix X, what is the thing that your Alliance isn't doing now that you wish it was, or the blind spot as you think about cancer in the community that needs attention, that either for resources or deficits in science, you're not there yet? Veena?
I think
just put you in charge. What would you change?
Yeah, I think that that strengthening the patient-clinician partnership is key. So just building on this theme that you've brought up, I think we need to have the patient voice as part of.
So, I mean, not to interrupt, but that's sort of therapy, that's care, and I understand, and we have like, chief nurse. You're like the chief nurse of everything, right? Or you administer all of them, right? So there's a care dimension here. I'm intimidated, but I sort of want to ask this question because there are two streams here that are very interesting to me. One is care, making something patient-centric, and I've always sort of wanted to know how do you scale that in a way that has broad replicable impacts that are good. And then the other dimension is when I'm doing an interview with this Microsoft guy here in a minute about AI. How does that connect with the research side? Sometimes I say to myself, I wish somebody, outside of, the cancer lines was actually just fixing it, curing it, so that these other dimensions not there. So explain to me where they intersect and where I'm naive.
So I'll give you an example. This is our hope is, as part of our research work, to kind of collaborate with companies and tech companies and others to try and do some innovative trials. And one collaboration we have started is with Microsoft to try and this came very much out of the work we've done engaging patients and with our network of clinical centers across the state to use technology to measure patient symptoms and vital signs in real time while people are starting chemotherapy, and see if we can utilize that information to prevent hospitalizations and ER visits during the course of therapy. Because this is a really troublesome problem for people, and it's obviously costly and traumatic. So that's one example of a project that is kind of bridging the research world, the clinical world, and the tech world. More examples of that kind of work, I think we need to move forward.
Terry, what would you add to the Alliance's objectives?
I think, as we look out into what the community is, the community, at least in the Pacific Northwest, is far-reaching. It's not the Seattle metro area like it is in other areas of the country. So then it's how do we leverage the tech and what's available to us in the innovation to bring the care to the patients where they are. Mm-hmm. We've got patients in Alaska, we've got patients in Idaho that don't have access to the academic center, that find it even difficult to get to the community clinic. So then how can you leverage the minds of a Microsoft and an Amazon to really help you bring the care that a Veena and the nurses in the clinic have to offer to the patients where they are? And I think it's really about...
Is that working?
It's starting to. We're at the very fringe of it. And I think in many ways the tech may be ahead of where we are as far as figuring out how the payment models work and how the documentation works. But we are seeing that the boundaries are starting to go away.
Boy, when you said payment models, my spine just stiffened. What's the deal with payment models? Like, is there a good one?
There's a million of them, and they're all different. And to say that one's good, one's bad, they're so different. They're so disparate, and it's hard to say that, oh, this is great, this is perfect, this is wonderful. We live in a world where we haven't quite figured that piece out yet. So we tend to focus less on that, and I know I brought it up as a talking point, but we tend to focus less on the how we're going to get paid. We let that come after. We really try to focus on how we get what the patient needs, because at the end of the day, the patient's the one that matters. They're the true north.
Veena, one of the things that I've also been interested in is the sharing of best practices. So I'd be interested if Seattle were to go on a show and tell tour and say, here's some things that Tulsa might learn, or that Tampa might learn, or Pittsburgh. What do you think some of the dimensions of the cooperative relationships that you think you've gotten right here that are moving the needles in ways that are not that might show Seattle's uniqueness?
Yeah, well, I I don't want to belabor this point of this report we put together, but I do think this is a prime example, this value in cancer care community and the report that we put together using the data from the state to look at variability and cost of care around certain metrics that we've identified is one of the first, most unique kind of reports of that nature in the country. And so what it's helped us to understand is, how do we care for people with certain kinds of cancers? How often are people getting chemotherapy at the end of life? How often are people being admitted to the hospital during chemotherapy? How often are people getting unnecessary or necessary surveillance testing after cancer treatment? The kind of things that we think really have evidence to support their use or lack of use in cancer care. And trying to understand how variable that is across the state, what it costs at different centers, to try and sort of come to then move towards standard best practices, because you can't really move towards that unless you understand the lay of the land. And so I think that's the first step. I think we've spearheaded that effort here, along with a lot of collaboration with patients and other centers. And I think that kind of thing.
How would you grade the literacy of those folks in your network about this? So I think what you said just makes a ton of sense. I have a cousin here, Marilyn. We've just actually met for the first time today, but we've known each other for years, and our families are from Bartlesville, Oklahoma. And I have to tell you, the Bartlesville, Oklahoma cancer community is not great in the sense of the kinds of resources. And so what you just shared about frames and having practitioners understand how to guide patients or to arm patients with the sort of literacy, how do we get that right? I mean, I'm obsessed with that, of how to build literacy among, essentially cancer doctors, and so that we're not just dependent on smart centers, but you can deal with the person in Alaska or Iowa or Idaho that may be in this. So what do you think the steps are on that front that could be helpful?
Well, I think you can probably comment on this too, Terry, but the pathways, treatment pathways are one example, and the SCCA has developed cancer treatment pathways in many disease areas that are, interpretable by clinicians and relatively easy to understand and kind of follow the framework that NCCN and other organizations have used. And the idea is to disseminate that information to
Terry?
clinicians.
I think it's about the sharing of information and really being willing to share what you perceive as your secret sauce and teach others to do it. We have a lot of network partners. We've got clinics in Alaska and Hawaii, all over the Pacific Northwest and beyond, that we partner with to share our best practices with them and also provide them access for information when we can provide it to them. And I think the work that Veena and the team do is they make that scalable. They make that information very easily shareable and digestible as we learn from all of the data that they're taking in and analyzing.
And Terry, I'm sort of told, and I'm gonna get this wrong, and I apologize because it's probably the wrong word, but my team told me that one of your enthusiasms is pancreatic cancer. It's sort of an odd way to put it, but walk us through that range of cancer for a moment and what you think the Alliance does with someone in that situation that creates a track that you're enthusiastic about moving the needle there with regard to pancreatic cancer.
So I always, you can't, a nurse is always going to bring it back to a patient. So we'll call this patient Dan. So 57-year-old gentleman diagnosed with locally advanced pancreatic cancer. 10 years ago, we had a handful of drugs, nothing particularly targeted. He would go through radiation, he would go through surgery, hopefully, and still have a 20% chance of 5-year survival. Fast forward to today, we've got information, we've got molecular genomics. We can take that person's tumor, we can identify variants, a BRCA variant, as a matter of fact. And because of the information we have, because of the data, because of the academics, because of the innovative thinking, we take something called a PARP inhibitor off the shelf, which is typically used for breast cancer patients. And after his second recurrence, we treat him with a PARP inhibitor. He's now survived a locally advanced cancer diagnosis of pancreatic cancer, 2 recurrences. He's seen his kids get married, and he's living a life that he wouldn't have been living were it not for all of this work that's gone on and all of the innovation. So that's the path, and pancreatic cancer is a passion of mine. I'm also a nurse practitioner in addition to my other hats, and I've cared for pancreatic cancer patients for about the last 14 years. And these patients are incredibly special. When they're sick, they get sick very quickly. And we're starting to see a world where maybe there's more hope than there was before. And that's what makes it real, and that's what makes all of this tech and innovation and data meaningful to the patient.
Thank you. I'm going to go to all of you in just a moment for comments, but Veena, I want to ask you, 2 of the most interesting books that I've read on this cancer, Sid Mukherjee's book, The Emperor of All Maladies, which was a big slog, but educated me about essentially, what was promising, but also frustrating in the cancer world. But then Joe Biden's book about the death of his son, essentially, and in there, so you would kind of look at all the great advances that are going on and things that Mukherjee's writing, and then you've got Hunter Biden, Beau's brother, basically trying to FaceTime between doctors in different institutions because they can't trade information or move information about, and data. And I'm just sort of interested, as you look at this and the Biden Cancer Initiative, whether you think it is something that has merit in kind of looking at this question of de-siloing some of the, having SAP in the mix with oncologists and others, and whether that's useful or do you think it's distracting? As I'm trying to get bearings on whether things like the Biden Cancer Initiative, and there's just more and more and more out there, whether it's noise or helpful.
Well, I think there are, at the most basic level, sharing medical records across centers around the country should be just a basic thing that happens. That's the bare minimum. But I think in terms of the kind of data that would be best shared is data around some of the biomarker information,
right,
and how, not just what the markers are, but how to translate that and how to understand what that means to a patient, because it's virtually impossible, I think, for an oncologist, especially a general oncologist, to keep track of all that information and understand the implications and understand that you would use a PARP inhibitor in the context of BRCA mutation. And so some platform to share that data and interpretation of that data.
Wow. Well, thank you. Let me go to the audience here. So we got one right over here. Say hi and tell us who you are.
Hello.
We have millions of people watching online. So.
Good. Hello, everyone.
Yeah.
My name is Joyce McCraney, and I am here representing King County Public Health Chronic Disease Injury and Prevention Division.
Right.
And I go out in families' homes, and I work with families that have chronic diseases. And my question is to the panel, why is, in 2018, all types of cancer so prevalent?
Right.
And we have to talk to our families now about what they eat, what they drink, things to watch out for, because everything could cause cancer. So why is it that cancer is so prevalent now in every area of our community, of our lives?
Thoughts on the prevalence of it? Terry?
Well, I think some of it ties to knowledge. Even going back 20, 25 years, the diagnostics were not what they were today. I think we have an awareness. I think we have an acuity. I think we're diagnosing more than we perhaps were before. But I also think we're now a generation that's been exposed to a lot. And we're also living longer. So I think it's kind of a multivariate issue here. And I don't know what Veena's got any additional thoughts.
Yeah, no, I think part of it is diagnosis. I think there are many cancers that are decreasing in incidence with time. There are some cancers that are increasing in incidence. For example, esophagus cancer involving the junction between the esophagus and stomach is a growing problem in this country. Colorectal cancer in younger people is a growing problem, and we've seen the guidelines shift to screen people at younger ages. breast cancer in younger women. So I think there are definitely certain cancers that are increasing, and we need to get out the message about some of these screening guideline recommendations.
I mean, I have, actually the similar view that it's become so prevalent in certain communities. And I mean, is there anyone in this room, put your hand up, who's not been touched in some way by cancer, or a relative or someone? But yet it is something where the stigma, there's still stigma of people living with it, dealing with it. There are issues related to work and flexibility. And it's remarkable how pervasive this challenge is. And yet we remain a kind of like, heads in the sand on certain dimensions of giving people what they need to do with it. So thank you very much. Another question or a comment from the audience.
Hello, my name's
Yes,
Christina
hi.
Loxton. I'm also from King County, but in my other...
And I take it because I'm not from here, but we're in King County, right?
Yes, we're in King
Cool. So
County.
this is your zone, all right. I heard of Kent County earlier, and I guess it's up north a little bit.
But most importantly, I have stage 4 breast cancer. And along the same lines of what you asked, now we know that cancer is a problem. It's increasing. What are we doing to prevent it? Especially when we know that vaccines for HPV, for instance, can prevent cervical cancer. So I'd love to hear what else you might be doing along the lines of prevention. Thank you.
Yeah, that'd be great. So, and we'll wrap it up here in this sense. Can you, Terry, and both of you share, particularly within the lines of the Alliance, what I think that this is a really question of reaching community and kind of moving the needle on awareness, on testing, on clinical trials, all of those dimensions, giving it extra muscle. What would you do?
Well, I think it's awareness, and there's so much more. Every day we learn more that we didn't know before, and I think really tackling the known things. I mean, we're working with the Snoqualmie tribe, for instance, on smoking cessation and healthy behaviors, because they're really concerned about their teenage population. There's a lot of smoking, there's a lot of unhealthy behaviors. It's getting the education going at a foundational level and really affecting the things that we do know can affect cancer.
Veena?
Yeah, and I would just add that, there's also a very robust cancer prevention group at the Fred Hutch who's doing research to try and understand, what are the predisposing factors in certain groups that make them at higher risk for cancer, and how can we maybe shift that trajectory. And then, of course, as you said, outreach for age-appropriate cancer screening. In fact, in our group, we, in addition to understanding data, we do interventional studies, and we're doing several studies trying to understand how we can improve colorectal cancer screening and lung cancer screening in high-risk individuals. And so these are the kinds of things that we want to try and do at a clinical level, but also try and understand at a research level what are the best ways to implement age-appropriate cancer screening.
And I just want to thank you for your candor and thank you for sharing, because I would just tell you I don't think that we're there yet in terms of either testing or awareness or literacy. You can probably see in the bias of some of my questions. But I would also say that as I've visited Penn Med or the Mayo Clinic or Moffitt Cancer Center, there's incredible gains. And not to talk about the sport of the day, but even in the private sector, when you look at the amazing advances that are being, and you look at what's happening with CRISPR and gene editing and immunotherapy and a lot of these other areas. And my worry is you have a lot of folks out there who are disconnected from how many advances there actually are in this. And it's not as bleak a picture as it might otherwise be. But thank you very much for sharing that. Please give a round of applause to Terry McDonnell and Veena Shankaran. Thank you so much.